respected senior faculty members, senior pediatricians, colleagues, and office bearers of IAP Pondicherry, I welcome you all for this program. First, I request Deepan, Dr. Deepan, Treasurer, to start with the pediatrician prayer. Irkara, sir?
Sir.
Yes, sir.
Sir, really honorable sir. So, pediatrician prayer, grant us the quality of holistic healing. May we humbly realize how privileged we are in being bestowed with the ability to alleviate suffering. May we be emissaries of health, learning, charity, love, and peace to all children and their families, irrespective of status and creed. Give us the wisdom, understanding to change the things we can, retain the good, and accept within reasons the things we cannot change. Grant us your blessings, grace, and mercy in all situations, at all times, and amidst all people. குழந்தை மர்த்தனின் இறையஞ்சல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும் நோயாரின் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்புரிமை என்பதை பணிவுடன் நாம் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவர் தம் குடும்பத்தினருக்கும் அவர்களின் சமுதாய நிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தவற்றை மாற்றவும், நல்லவற்றை உள்வாங்கவும், மற்ற முடியாதனவற்றை காரணத்துடன் ஏற்றுக்கொள்ளவும் போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள். தேங்க்யூ சார்.
Hello. Next, I request our respected President of IAP Tamil Nadu to give inaugural address.
Thank you. Most respected our Dr. Sangyaravel sir, the scientific advisor and past VP of South Zone. On behalf of IAP TNSA, welcome sir. And I welcome today's speaker, Dr. Rajkumar, as well as Dr. Manasi. So Rajkumar is a current professor of pediatrics, Madurai Medical College, as well as treasurer IAP TNSA. And on behalf of IAP TNSA, I welcome all the Pondicherry Academy of Pediatrics, President Dr. Johnson Reddy, and past President Dr. Adis Sivan, and Narayanan, Vice President, and as well as Vinod Kumar, Secretary, and Treasurer Dr. Deepan, and my friend, and as well as my brother Dr. Thirumurugan, Academic Coordinator. And it's a great pleasure to privilege to be here as a Pondicherry chapter of pediatrics webinar. This today's topic is the rationale of antibiotic day. It's a really need to create awareness of antibiotics. Usually our my mentor Dr. M. Ramsamy says start with your career with the 60 medicines and end up your career with 6 medicines, like that. So we are initially will write so much of antibiotic. Once you are getting more aged and more than that so maturity, so you will definitely reduce the antibiotic. And so that's important things. We have to aware that rationale of antibiotic. Particularly, we have to educate pharma people as well as that's young pediatricians. They have to avoid unnecessary antibiotic use also. So this definitely will be useful and eye-opening for the youngsters and as well as pediatricians. On behalf of IAP TNC, really appreciate that effort of Pondicherry Academy of Pediatrics taking important step to create awareness among pediatricians. Thank you very much.
Thank you, sir.
Thank you.
Yes, sir. Thank you, sir. And next, I request President of IAP Pondicherry, Dr. Johnson Reddy, sir, to give welcome address.
Respected President Dr. Rajendran sir, and all the office bearers, and our senior pediatrician, and our nominee for national president, Dr. Singaravel sir. Welcome you all our colleagues and dear friends. It's immense pleasure to be with you for this important seminar on rational use of antibiotics. We all have to refresh our knowledge and follow this as a dictum so that and also pass on this knowledge to the next generation so that we save some antibiotics for future use. Thank you, sir.
Thank you, sir. Next, I request our mentor and patron, Dr. Srinivasan sir, to give address.
Hello, wish
Hello,
you all
sir.
the best. I will not waste your time. So it's good that it's continuing, and I'm eager to listen to you all. Thank you.
Thank you, sir. Thank you, sir. Next, I request our past president of IAP Tamil Nadu, Dr. Aram Chandil sir, to give address. Chandil sir? Yes, sir. Vanakkam, sir.
அண்ணா
Vanakkam.
வணக்கம். நீங்க இருக்க தெரியல, உங்க பேர் சொல்லியிருப்பேன்.
Good evening.
நான் செல்போன்ல ஜாயின் பண்ணதால தெரியல.
ஐயோ பரவாயில்ல
டாக்டர் சீனிவாசன் சாரையும் தெரியாம போயிடுச்சு. சாரி. ஓகே, ரைட்.
So it is a pleasant task given to me, and definitely in front of the teacher of teachers, Professor Srinivasan sir, and IAP TNSC President, Dr. Rajendran, and presidential aspirant candidate, Professor Singaravel sir, and the President, Secretary, and Treasurer of IAP Pondicherry branch, which is conducting this Zoom meeting for National Antibiotic Day. And of course, the person behind IAP TNSC's upliftment during the past 5 years, Dr. Tirumurugan. So it is all really thanks for giving me this opportunity. And definitely this type of continuing medical education and the rational antibiotic usage is definitely a necessity nowadays. We all know about it, but we have to see that even the general practitioners and those who are seeing pediatric patients are still writing cefixime for respiratory infections. So this has to be combined with Indian Medical Association and has to be seen that all the viral infections do not need antibiotics. So this is the scenario now. And in this present H3N2 season, we are all seeing so many fever patients. So we have to restrict the usage of antibiotics. Let us take it as a definite message and see that we prescribe definitely for the benefit of patients, for the non-development of resistance, antibiotic resistance. So thanks for the opportunity. Thank you so much.
Thank you. Thank you, sir. Next, I request Dr. Shanmuganandan sir, our state EB, to give some words. Shanmuganandan sir. Okay. Next, I request our president-elect nominee and our mentor, Professor Dr. Singaravel sir, to give address in this forum.
Thank you, Vinod, for the
Yes, sir.
wonderful opportunity
Welcome, sir.
given to you. And good evening to all. The most dynamic state president, Professor Rajendran, and our immediate past president of our IAP, Dr. Sendil, and our academic coordinator, Tirumurugan, President Johnson team, Vinod, and Arul Kumaran, and other lot of our teacher of teachers, Professor Srinivasan sir, and my co-EB member last year who did exceptionally very good work, Shanmuganathan sir, and all those who joined in the platform in Pondicherry Pediatric Forum. I should thank all the office bearers of Pondicherry, including my good friend, our Tirumurugan, who is doing extremely well, taking our IAP TNSC into very high level along with Dr. Rajendran. So I don't want to talk much regarding the topic because the experts, Madam Manasigar, is a pediatric nephrologist. Definitely, she will going to deliver a very good talk, and my good friend, our treasurer, is going to give a both are going to talk about the important topic on the observation of our National Antibiotic Day webinar, where it is the need of the hour, because over a period of time, definitely the awareness has come to our pediatrician, and it should percolate into the practitioners in a better way. Otherwise, even now, we are seeing people practicing in the periphery. Moment when a child comes for fever a day or two, they immediately have start the habit of writing antibiotic. So definitely this webinar and two related to nephrology, because what are the complications we come across when we use antibiotic, then people will realize before they will start thinking before ink. That's what we always mention. Before ink, you think. So before writing any antibiotic, we should think of it. Definitely, both the speakers, our Rajkumar and Manasi ma'am, will deliver a very good, useful topic to all the practitioners, and it will be really beneficial. So my congratulations to all the participants and to the speakers for a great success. In turn, our IAP is doing a lot of good things to educate our own members for betterment of the care to children. So with this, I once again thank all the organizers for giving me this opportunity. With all your blessings, support, encouragement, and especially our Tamil Nadu IAP TNSC with Pondicherry, our President Rajendran and Sendil, our Thiru, everybody is doing, our Balashankar, whoever is there. So everybody is doing with our members that our IAP Tamil Nadu Pondi should get a president after 28 years, for which we are all working together. We need your support, encouragement, and especially your president, Johnson Reddy, took extraordinary strain where he was in Odisha with a difficult situation. But still he went and met people and called, and really he did a great thing. So that is the spirit of IAP of Tamil Nadu. So with this, I thank once again for giving me this opportunity. Thank you all. Over to Vinod.
Thank you, sir. Thank you, sir. Thank you, sir. Lastly, I request our beloved academic coordinator of IAP TNSC and also Central IAP EB member of Pondicherry, Dr. Tirumurugan Charan, to give address and also introduce the speaker for today's topic. Thank you, sir.
Thank you, Vinod. There's nothing much for me to address except that I'm really delighted to have a webinar on behalf of IAP Pondicherry after a very, very long time. I think IAP Pondicherry got the National Antibiotic Day celebration first place last year in IAP TNSC. And so we thought we should try to continue the tradition and work on trying to get it again this year also. So that's part of the reason why we chose it. Of course, it's really important that we should have rational use of antibiotics. And I think we have got two eminent speakers today, Dr. Manasi, who basically is a trained pediatric nephrologist in our region, who is going to talk about why it's important to have rational antibiotics for when it comes to pediatric nephrology. First, kidney is going to take the biggest hit of all the organs when it comes to irrational use of antibiotics. And of course, from a practical point of view, what we need to do daily is about in the office practice. And about that, we have an equally eminent speaker, Dr. Rajkumar, our treasurer of IAP, that's going to talk about it. So I think I will not hold you guys ransom by delaying this topic any further. Over to Dr. Manasi for starting it. Thank you.
Thank you, sir. for the opportunity, and I thank you, IAP Pondicherry branch, to give me this opportunity to talk on a very important topic, National Antibiotic Day. National Antibiotic Day. I'll just share my slides. Are my slides visible?
They are.
Yes, ma'am.
Just need to go to slideshow.
Okay. So I'll be talking about the topic in the 4 parts: problem statement, why we should use national antibiotic, which is already very well covered by Aram Sintil sir, and common scenarios in pediatric nephrology, and what is ninja action. So the global burden of antimicrobial resistance, WHO has seen that globally at least 4.7 million deaths and 1.4 million deaths are due to infections caused by bacterial resistant drug infection. And in an article by Lancet, it has been said that at least 39 million deaths will be directly contributable because of this bacterial drug resistant infection if we do not step in, take some action to prevent antimicrobial resistance. That will equate to almost 3 deaths every minute. The antibiotic drug combination, what they have seen is Staphylococcus, which is resistant to methicillin, Acinetobacter, and Streptococcus pneumonia, which are resistant to carbapenem. These are creating havocs and deaths. Coming to Indian scenario, among all the 204 countries, India ranks at 57th position in relation to antimicrobial resistant deaths in 2021. Coming to children, among the 1.4 million deaths which were happening, almost 1 in every 5 deaths was of a child who's younger than 5 years of age. And this equates to almost a child dying nearly 2 minutes. And most of these deaths are seen in low or middle income countries. India itself has more than 56,000 children dying because of antimicrobial resistant associated infections. So why is rational antibiotic usage important? Because its misuse can lead to toxicity, it can cause resistance, and the cost of therapy, hospitalization stay, it increases and puts a pressure on the doctor as well as the parents. Many patients are at risk, pediatric nephrology, which I'm going to talk about, newborns, because a newborn, when is exposed to multiple antibiotics, in future, it becomes very difficult to manage those children. Rational use ensures better outcomes. What are the causes of antimicrobial resistance? Suboptimal duration and frequent use of antimicrobials. Once we give a course of 3 days or 5 days of antibiotics, once the fever subsides, the patient stops taking the medications. And if the fever recurs, they go and take over-the-counter medication for the same fever without going to a doctor. Irrational prescription and potent antimicrobials which are being available, and antibiotic self-medication. Because of the antibiotics being available, they just go and take antibiotics, which is causing a lot of antimicrobial resistance. The common scenarios which we see in day-to-day life are urinary tract infections, nephrotic syndrome, acute nephritic syndrome, chronic kidney disease, and CLABSI. So any child with fever who's coming without a focus for more than 48 hours, the recent guidelines of ISPN guidelines, Indian Society of Pediatric Nephrology guidelines, which are published in 2021 for UTI, states that as first line for screening can be a dipstick test and a urine routine. If the child is symptomatic, and in the dipstick, if there is a leukocyte esterase positive or nitrite positive, we can go ahead and start empirical antibiotics for the child. Depending upon the age of the child and the risk factors present, whether the child is having vomiting, is the child not able to take orally, we decide whether to give an oral antibiotic or a IV antibiotic. What are the other risk factors? Bowel bladder dysfunction or BUR, or is there any history of previous UTI? Which antibiotics to be given? If it is a pyelonephritis, third generation cephalosporin or amoxiclav are preferred orally. We can give IV antibiotics if the child is not taking orally for 3 to 5 days and change to oral as early as possible. If it is a case of plain cystitis, first generation cephalosporin or amoxiclav for a duration of 5 to 7 days is recommended. Any child with asymptomatic proteinuria, we need not start antibiotics. We can wait till the culture report comes. Now, how do we interpret what a culture tells? If you see, the guidelines have changed here again. If earlier it was, if there is suprapubic aspiration, any colony forming unit is considered significant. But now it says that 10 to the power 3 colony forming unit per ml is considered to be positive in a suprapubic aspiration sample. Urethral catheterization is same, 10 to the power 4 colony forming unit. And when we go for a clean catch method, again, the colony forming units are 10 to the power 4 to 10 to the power 5. So if a child is symptomatic and the colony count is 10 to the power 4, we still take it as UTI and we still treat the child for 7 to 10 days. The recent guidelines which are published is basically also focusing as preventing or overusage of antibiotic prophylaxis, which was being done a lot whenever we have a child with bilateral antihydronephrosis. So the recent guidelines very clearly says that if you have a child with antenatal hydronephrosis who's awaiting evaluation, do not start uroprophylaxis. Do a MCU. See if there is a VUR. If the grade of VUR is 3 to 5, start uroprophylaxis. If there is a recurrent febrile UTI, along with a bowel bladder dysfunction, or it is a child, infant with a recurrent febrile UTI, even with a low-grade VUR, antibiotic prophylaxis is recommended. A normal urinary tract without bowel bladder dysfunction, or a child with antenatal hydronephrosis who's waiting for evaluation, we do not start uroprophylaxis. The drug of choice, cefixime in less than 3 months of child. And if the child is 3 months or older, we give cotrimoxazole or we give nitrofurantoin. Now, it is also very important once we start uroprophylaxis, we should be able to discontinue it as early as possible to prevent the resistance. So we do prevent uroprophylaxis, discontinue the uroprophylaxis in a child who is more than 2 years of age, and if they are toilet trained, there is an absence of bowel bladder dysfunction, and there has not been a single episode of UTI for last 1 year, we can very well discontinue the uroprophylaxis. Over the years, they have found that antibiotic resistance in UTI is increasing, even for amoxicillin. E. coli is the most found organism, which is 76%, and the resistance even for amoxicillin has increased from 16 to 36%. But still, amoxiclav is a good to go drug, and Indian society still recommends amoxiclav as first line of drug. And they've also found that antibiotic resistance was found in children who were given antibiotic use, who were given prior antibiotics. So their antibiotic resistance was high. Now coming towards nephrotic syndrome. Again, the revised guidelines have come up in 2023 for nephrotic syndrome. Routine prophylactic antibiotics are not indicated in any of the nephrotic syndrome child. To see an infection in a nephrotic syndrome who is already on steroids is very difficult. So it is very crucial for all of us to promptly recognize if there are any signs of infection and to start appropriate antibiotics so as to prevent a life-threatening complication, as these children are already on an immunosuppression. A normal infection going into a life-threatening complication is very high. And also, if there is an infection, the chances of relapse increases. And routine urine cultures are not necessary in a child with nephrotic syndrome. When we do the first set of investigations to diagnose nephrotic syndrome, urine routine is mandatory along with the urine protein creat ratio, but not a urine culture. We might get urine culture sometimes positive. It can be an asymptomatic bacteriuria. The most common infections what we see in nephrotic syndrome children are pneumonia, followed by peritonitis, cellulitis, and sepsis. These are the drugs which are recommended in the new guidelines for each of the infections. Coming towards acute nephritic syndrome, we all know that most of the cases of acute nephritic syndrome are infection related, and most common infection is post-streptococcal glomerulonephritis. So antibiotics are recommended only when there is an evidence of an underlying infection. Again, post-streptococcal glomerulonephritis. In PSGN, we don't give antibiotic to prevent acute glomerulonephritis, but it is to prevent the transmission of streptococcal infection. Drug of choice is penicillin B, erythromycin for penicillin allergy, and this has to be given for 10 to 14 days. Also, a point of caution, a word of caution here, please avoid amikacin and vancomycin in these children because they are highly susceptible to AKI, acute kidney injury, and amikacin and vancomycin may precipitate. Also, please avoid ACE inhibitors in these children because ACE inhibitors for hypertension, because again, ACE inhibitors can worsen the renal function. Coming towards CACUT, congenital anomalies of kidney and urinary tract, we have many children who have antenatal hydronephrosis or a multicystic dysplastic kidney or a solitary kidney. So whenever a child is having a VUR or any CACUT, they are at risk for UTI because of the anomalies. So we have to be very sure of what anomaly is and when is the uroprophylaxis needed and which antibiotics to be avoided to prevent a nephrotoxicity, because these children may have only a single kidney. So any antibiotic when we prescribe to these children, we should be very careful that we are not prescribing aminoglycosides or vancomycins or antifungals which may be nephrotoxic. So these children are at increased risk for UTI. Antibiotic prophylaxis are prescribed when a high-grade VUR is diagnosed, or if there is an obstructive uropathy, or there is a recurrent febrile UTI. Again, as given in UTI guidelines, cotrimoxazole and nitroglycerin are the drug of choice after 3 months. And higher resistant rates and UTI with non-E. coli organisms are observed in children with CACUT. Coming towards chronic kidney disease, as per the definition, any structural abnormality or any functional abnormality which is present for more than 3 months is called as chronic kidney disease. So whenever we have a child with CKD, we always need to remember whenever we are prescribing the drug, because they are at higher risk because of drug misuse and over prescription of antibiotics. They have frequent hospitalizations and invasive procedures. They may have frequent UTIs, dialysis-related peritonitis or catheter infections, requiring a lot of antibiotics for same and leading to higher antibiotic resistance. There are also on immunosuppression with drugs. Many times a nephrotic syndrome child, a steroid-resistant nephrotic syndrome, may develop CKD. And for that child, we might need to give alternative immunosuppressive drugs like MMF or CNIs like tacrolimus or cyclosporin or rituximab. So these children are immunosuppressed with high chances of infections because being on dialysis, that leads to antimicrobial resistance, as well as any antibiotic which we give may cause nephrotoxicity. So because of overuse of antibiotics, we have MDR pathogens like ESBL producing E. coli or Klebsiella in UTIs, Staphylococcus and vancomycin resistant infections in dialysis catheters, and carbapenem resistance is seen in transplant patients. So what happens if we use antibiotic non-judiciously in children with CKD? We have higher morbidity, treatment failure, and higher cost. As I already told, the chances of nephrotoxicity and superinfections are high. So whenever we give a child in CKD any antibiotic, please look at the serum creatinine values, calculate the eGFR, and estimated eGFR. Depending upon the stage of CKD, we need to provide a renal adjusted dose. Avoid any nephrotoxic drug because it will be a second hit. It will further lead to AKI, and avoid unnecessary prophylaxis when not indicated. Then coming to HT catheter related bloodstream infection in children who are on chronic hemodialysis because of using antibiotic lock or over usage of antibiotic of more than 30%, multi-drug resistant organisms are being found in children in the dialysis center. So an immediate need is to develop an antimicrobial stewardship program for dialysis related programs. A word about NINJA, that is nephrotoxic injury negated by just-in-time action. This is a multicentric study, almost 9 countries it was being done. And it is basically to improve the nephrotoxic stewardship, like in ICUs, we do use a lot of nephrotoxic medications. So they say that if there is a high nephrotoxic exposure, that is, if the child is on 3 or more nephrotoxic antibiotic given on the same day, or at least 3 days of continuous IV aminoglycoside is being given, then we should do a serial monitoring of creatinine daily and post stopping the antibiotics for 2 days to see what is the chances of acute kidney injury. So this NINJA has helped to actually curtail the toxicity levels or the acute kidney injury levels by 30 to 45% in many centers. So this is one we should be looking at. So how can we prevent this? Is by reasoning for prescription, right dose, duration. We should also be updated with the new guidelines which have been come. Training of mind, residents, parents, pharmacists. We should always tell the parents that every fever does not require antibiotic. A fever can be a viral fever. We need not give antibiotic for each and every infection what we encounter. We need to see what the cause of the fever is or the organism search. Note down the diagnosis and give the antibiotic for that particular day. The duration of antibiotic course is very important, and to counsel the parents about the following it. The compliance is very important. Local sensitivity pattern should always be kept into mind. And if a child is CKD, or we should remember the drug dosage according to EGFR. Ethical consideration, economics can also be taken into consideration. So antibiotic resistance is the threat to our health. If we save antibiotics today, we have a better future. Thank you.
Thank you, Dr. Mercy. I think we don't have any questions right now, so once we probably take the questions right there. We now request our Director of IAP TNSC, Dr. Rajkumar, to start this topic. Over to Dr. Rajkumar.
Thank you, Thiru. Thiru, am I audible?
Yeah, you are.
Okay. I'll share the screen now.
Yeah.
Okay. Now, is it visible now? My screen?
Yeah.
Thiru?
Yeah. Your screen is visible, but
now.
Yeah. Can you just probably go through the? Yeah.
1 minute, Thiru. I'll hide it.
Yeah.
Right. Okay.
Yeah, that's fine.
Okay. So, good evening, one and all. First of all, I would like to thank the organizers of today's CME for giving me this opportunity. Let me, first of all, I would like to thank Chairperson Dr. Singaravelu sir, and IAP Pondicherry President Johnson Reddy sir, Adisivam, past President, Vice President Narayanan, Secretary Vinod, and Treasurer Defane, and of course, the all in all, Suravali of Tamil Nadu, Dr. Tirumurugan sir, and as well as my the resource person, Dr. Manasika. So what I'm going to talk in the next 25 minutes is about myths and misconceptions in antibiotic use. We all know how, before going into that, let me say this. I always start my slide with this. This is, you all know, Dr. Singaravelu sir. Please vote for him. Make your friends vote for Dr. Singaravelu sir. Okay, right. This is my biodata. Of course, you all know about myself. I am the treasurer of Tamil Nadu IAP TNSC and professor of pediatrics at Madurai Medical College. Right. Let me start with a case scenario. Right. This is a common scenario we see every day in our OPD practice. A 3-year-old child comes to our OPD with a 2-day history of sore throat, there's nasal congestion and low-grade fever. On examination, everything was fine. Otherwise, even chest is okay. But what we do, the physician immediately he prescribed amoxicillin for 5 days, because what he thinks, it is like, he thinks like ethically he has to give antibiotic to this child because it will speed up recovery. This is a common myth we have, right? This is a case scenario 2. This also will be a very common one, I can say. This is a 6-year-old child admitted with community-acquired pneumonia. He was very sick when he came. He was having dyspnea, tachypnea, and X-ray chest was showing lobar consolidation. He was started on ceftriaxone with azithromycin empirically. What happened after 3 days? He was fine. Everything he settled nicely. Febrile saturation initially was low. Now it is picked up nicely, 95% on room air. Even symptoms improving. The dyspnea has now disappeared. Cough is only there. But what happened? The blood culture it was sent on the day 1. Now it is showing cons. This is, we almost like we see every day. Cons is now there. Coagulase negative stuff, albus, and it's resistant to ceftriaxone but sensitive to levofloxacin. So what the pediatrician immediately what he did, he discontinued ceftriaxone, he added levofloxacin because he is telling that the patient is improving, but the culture report has come which is telling that ceftriaxone is the organism is resistant to ceftriaxone. So many antibiotic myths we have. I can say it's innumerable, but what I'm going to do in the next 25 minutes, I'm going to take 10 to 20, 10 myths. Before that, let me start with a story. This happened in 1940. This is at the start of the Second World War. What happened? France was having Germany was attacking France, and France, what they did, they put the army in 2 places, here and here, and Germans, cunningly they attacked through this way. And after 10 days of this, Winston Churchill, he's allied, he's the Prime Minister of Britain. He came to France. He came to Paris because the German army is just 25 kilometers away from Paris. So he asked the Gamelin. Maurice Gamelin was the chief army general of France at that time. He asked in French, Pondicherry, that what's la masse de maneuver? Where is the strategic reserve? And Maurice Gamelin, he was the chief army general of France. He said, "Aucune, none. There is no strategic reserve." And that within 10 days, Paris fell and France fell, and it took another 5 years of bitter fighting to overcome Germany, Adolf Hitler, and to win Second World War. It is a historical one. And let me tell you another similar thing which is happening. In the lower picture, you can see the antibiotics which have been approved since 1941. The penicillin came in 1941, and in 42, Staph aureus was found to be resistant to penicillin. Then you can see each year shows here the antibiotics one by one coming, and immediately the bugs developing resistance. You can see the Ceftazidime avibactam still we are not at all using, but already Klebsiella has developed resistance within the same year. And where is the strategic reserve? Now see the antibiotics which have been coming like a tsunami in the early part of 20th century. It was coming down slowly. By 1990, it was only 1 or 2 antibiotics. After 2000, almost 1 or 2 molecules are being approved every day. 2010, very less. In the last 5 to 10 years, we got only maximum 20 to 25 molecules, and that are also is still on the bench. Now, still haven't come to the bed. Still in the laboratories because they have a lot of toxicities. The cost is very high. The discovery is void, almost. So, where is the strategic reserve? I want to ask all of us. It's the question I'm asking myself and myself as well as yourself. And why this happened? Globally, the previous speaker has nicely told, I put only one slide for that. The antimicrobial resistance is causing 13 lakh deaths annually. And Tamil Nadu, Indian statistics already told. And why this is happening? There are multiple reasons. They say 1/3 it's due to misuse of antibiotics by like in poultry and animal feeds. Okay, 1/3. Another 10% because our people they go to medical shop and they buy antibiotics and they misuse it. Okay, what about the 60%, the chunk of antimicrobial resistance? Where does it come from? It is because of inappropriate antibiotic prescribing by us, which drives this resistance and which is harming the patients, right? Now you may ask me, and this is the doubt whenever I tell my students the inappropriate antibiotic use, they ask which is what is inappropriate, what is the appropriate one, எது தேவையான எது தேவையில்லாத ஆணி, right? So what CDC has told, up to 50% of our antibiotic prescriptions, they didn't come to our village prescription. Maybe they didn't see, it must be more than 70-80%. 50% they say it's a worldwide one, they are inappropriate. And we know the consequences, the increased resistance, adverse effects, all those things the previous speaker nicely told, right? So my objective, I'm going to take 10 common myths and I'm going to counter these myths with evidence-based practices. At the end of this, for each myth, I'm going to give you actionable recommendations. What are the rational prescribing principles and antimicrobial stewardship? I'll touch upon, I will not go into details, right? We'll see. Okay, well, this is the myth number one. I have taken the topmost myth that antibiotics for all respiratory infections, fever. Anybody comes into our OPD with cold, pharyngitis, short-term fever, 1 day or 2 days fever, we give antibiotics because the thing is, like, we are supposed to give. We are doing only good to the patient. Are we doing? Is it correct? No. The reality is, most of these URI and acute febrile illness, they are viral. They are self-limiting, and this acute febrile illness. Apart from viral, they be other non-bacterial causes also, autoimmune, other things. So I asked Grok, that AI, give me the summary of estimates from CDC, IDSA, and various studies, national and regional studies, and give me the viral and the bacterial etiology of ART and AFI, and that I put in the next slide, right? This is, I got it from the Grok. It went into whole internet, they searched, and it is, what is, this is like shock. I thought, the bacterial might be more in children. The etiology of viral etiology of ART in children is 70 to 90%, while bacterial is only 10 to 30%. While in adults, this could be more when the age, more than 60, this might be more bacterial. But for pediatrics, if you are prescribing antibiotics, you are going to be correct only 10 to 30% times. The rest of the times, you are going to be wrong. What about acute febrile illness? Again, the viral etiology is almost 55 to 70%, while bacteria it's about 20 to 30, and parasitic is about 5 to 10%. So this is the one we have to understand first. So you may ask me, when to use antibiotics in ARTA then? We have clear-cut indications for antibiotics in our OPD whenever a child comes with acute bacterial sinusitis or ASOM. Yes, we can use, or severe pharyngitis when the MAC-ISEC score, that is the modified Centaur score, is more than 4. So this is the one you can, every one of us must have heard this, the MAC-ISEC score. When this 4 is there, you can use antibiotics. There is no other way. And when a child admitted with severe pneumonia, even if it could be viral, we have to put antibiotic. We don't know, there could be, like superadded infection and suspected whooping cough. When the cough, it resembles that of whooping cough, we have to give antibiotic. Macrolides have to use. This is for antibiotics in ARTA. And what about acute febrile illness? When a child comes, looks very toxic, when the fever is very, very high fever, more than like 104 or something, or child has septic shock, definitely we'll admit, but toxic and more than 104, definitely we have to use antibiotics day 1 or day 2. You don't worry about because all this I'll tell later about the test, maybe become positive only after 24 hours. And fever with localizing signs, of course, with UTI and skin infections and soft tissue infections, you know that it is going to be bacterial. Yes, you can start antibiotics. And of course, when the fever is lost for more than 5 to 7 days without focus, in our area, enteric and scrub typhus, they are very, very common. And if not treated with antibiotics as early as possible, they may develop serious complications. We have to start antibiotics in these children. And please remember, extremes of age, like less than 3 months, if you are in doubt, start antibiotic. They say even up to 1 year, any child you suspect child is having little bit, the infection could be bacterial, start antibiotics up to 1 year. You have no other go. And some child, even ma'am, if child is malnourished and having an infection, yes, you can start antibiotic. And of course, primary and the secondary immunocompromised or child nephrotic, taking steroids, developing an infection, yes, you can start antibiotic. And please use inflammatory biomarkers in your office practice when you are in doubt. CBC, CRP, Procal. Procal is costly, but CBC, CRP, you can do it and you will get the results within 30 minutes. So I put a rough idea about the CBC. CBC showing more than 15,000 and left shift. Yes, it's going to be bacterial. Start antibiotics. CRP and after day 2, if it is more than 40, start antibiotics. Less than 20 is definitely viral. 20 to 40, you look at the holistic view. The child looks little bit toxic or sick, fever 102, 103. Yes, more than 20, start antibiotics. And Procol, of course, it's costly. More than 0.5, we are going to start bacterial, and we'll start antibiotic, and less than 0.25 is viral. Right? So the key points I would like to say about that myth is avoid antibiotics for viral pharyngitis or bronchitis. No need for antibiotics. You ask the patient to come after 2 days, and if the symptoms continue and child becomes a little bit, like a fever continues, yes, you can start antibiotics. But avoid empirical antibiotics for this, and avoid empirical antibiotics for any acute febrile illness apart from the conditions I told. And educate the patient. Sometimes the parents will eat your head. They will demand you to start antibiotic. You have to educate them to reduce the demand. And of course, this is a joke. We all know fever is not due to ceftriaxone deficiency, right? So we'll move on to the myth number 2. Again, diarrhea. Any child comes with diarrhea, we put antibiotic. That Normet or ofloxacin, arnitazole. My God, it is a misused drug, right? We'll see what is the reality. Again, I asked Grok, what about give me all these CDC or Indian studies, various studies. Give me what are all the breakup of viral and bacterial, right? We'll see. Can see the AGE in children. Again, viral constitutes 70 to 90% etiology, and bacterial constitutes only 10 to 30%, and protozoal less than 5%. Please remember this: less than 5% is due to amoebiasis or giardiasis in children. Adults, of course, the bacterial increases with age, right? So when to use antibiotics in AGE then? If I am saying don't use antibiotics, no, there are exceptions for everything. If child presents with acute colitis, that blood and it's not blood. Dysentery is blood and mucus, and acute colitis, loose stools mixed with the mucus. It could be Shigella, Salmonella, Campylobacter. So you can use antibiotics. Or when the stool resembles that of cholera, rice water kanji, yes, you can start antibiotic. Of course, PM child, very very young and immunocompromised. Of course, you have to start antibiotics in AGE. Okay, what antibiotics to start? Right. This is the one we are using right and left, by our village brothers, and even in tier 2 cities, normetrogil or ofloxacin. Please don't use. It's a irrational combo. This ofloxacin and norfloxacin and metrogil dose. They are. It's not. It's a correct dose. And of course, we know protozoal, the prevalence is only 3 to 5%. So add flagell only when it is indicated, and use cefixime. It's a wonderful drug for diarrhea. When it is indicated, you can use cefixime. In older children, you can go for doxycycline. No, don't use Cipro, Norflox, cotrimoxazole. Almost 80% of bugs in India, they show resistance to these drugs because of the overuse or our abuse, right? So the key points, we have to prioritize rehydration. This is the most important one. Recently, one study they done in all this, where they look at the prescription by the various pediatricians. They found only 15 to 20% of pediatricians they write ORS for a child who comes with diarrhea. It's a very very sad and unfortunate thing. We have to prioritize this one and limit antibiotics and reserve antibiotics only for the above mentioned conditions. We'll move on to the myth number 3. We'll move fast now, because the first 2 was a little bit tough. The broader is better. We always think that when we want to start an antibiotic, always we think that we put a antibiotic as broad as possible so that it will cover all possible organisms. It's like Arnold Schwarzenegger taking that big machine gun and shooting in the dark. You remember that in Predator. Like we want to be like Arnold Schwarzenegger. What's the reality? Using this broad spectrum antibiotic in our day-to-day practice as empirical therapy, actually it makes these bugs develop resistance. One famous example is so many hospitals in Tamil Nadu, in India. Okay, I'm not pointing towards Tamil Nadu. In India, they have developed AMC producing organism. There is like ESBL, that extended spectrum beta lactamase, one of these AMC producing organism, because we are misusing ceftriaxone. Any child or any person getting admitted in GH is getting ceftriaxone. You can come and you can check anywhere in India or Tamil Nadu. Invariably, ceftriaxone would be there in the prescription. And ultimately, we have all these ESBL producing bacteria. And we all know that using this broad spectrum, it is going to impact the microbiome. You know that gut microbiome, it is actually an organ which is doing a lot of wonderful things in our body. And this one would be, when it is altered, there are a lot of complications may arise, and it may lead on to Clostridium difficile infections. So we have to choose empirical narrow spectrum antibiotic to target the most likely pathogen. So we all know that WHO started in 2021 that AWARE campaign. AWARE is that access and watch and reserve. They divided all drugs we have into three groups. Those 48, they are the one to be used as a first line antibiotic. A famous example would be amoxicillin or nitrofurantoin. And watch, we have to be very, very careful. They are critically important antibiotic. They may induce high resistance. So quinolones, macrolides, even our third generation cephalosporin, they come in the watch. And reserve, please do not use at all, in the first line of therapy or in the OPD. They are to be used as a last resort antibiotic. One famous example would be, I'll tell in the next slide which one. So this is the one, this I have taken from, I went to IAP, AAP, everything. This is a consensus, the expert consensus. Choosing antibiotics in OPD, you can run your OPD with only 3 or 4 antibiotics, more than enough. Above diaphragm, any infection, go for amoxicillin. Below diaphragm, go for cefixime. Skin and soft tissue, go for cephalexin. This is the basic bare minimum antibiotic you need to treat any child comes with any community acquired infections. And if you suspect rickettsial or mycoplasma, add azithromycin or doxy. More than 5 years usually. So these 4 antibiotics are more than enough. If you are using any other antibiotic, really you are misusing that antibiotic, right? So this is the antibiotics for IP care. The Ampigara we used, in 20 years, 25 years back, we used as the first line therapy. But AAP and IAP now they say with respiratory infections, go for comoxiclav and cefiraxime. They are the best drugs. Cefiraxime is the second generation cephalosporin. Wonderful drug. Can use it as a first line drug. And second line, if not on a child not responding or not improving, go for third generation cephalosporin, piptas. You can add amikacin or clindamycin as and when needed. And third line, we are not supposed to go. Only the experts, they have to add Miro, Vanco, linezolid. Experts means the ICU specialists or any other person who is suggesting this. And when you suspect staph aureus, start cloxacillin. And nowadays, I've seen the postgraduate, they think whenever they think of staph aureus, they want to go for vancomycin. No, gram per gram, cloxacillin is more superior than vancomycin actually. When MSSA, cloxacillin is the best drug for MSSA, and only for MRSA, that only hospital acquired, we have to go for vancomycin or linezolid. And there is an MRSA community acquired, we all know. Cotrimoxazole or doxycycline gives wonderful relief in MRSA with community acquired. So the key points: use narrow spectrum antibiotic as far as possible as first line, avoid broad spectrum antibiotic, and use culture guided therapy and de-escalate. As well, of course, you have to follow the national guidelines. Okay, well, let us move on to the myth number 4. Newer antibiotics are better. We always know this representative, they come and they coax you, they cajole you, they tell this is the best antibiotic, now it has come into the market, this is the best one, older ones are useless. No, the reality, the newer antibiotics are developed to target the resistant bacteria, MRSA, the CLAP3, and MDR, gram-negative bacteria. And these are all very, very costly drugs. They have a lot of adverse effects too. And older antibiotics, the old is gold. They are the best still. Now they are excellent at treating infections. Like for example, penicillin is still the drug of choice for GABHS infection, diphtheria, gas gangrene, syphilis. Now it is almost 80 years after it's produced, still being the best drug. And this is the one I wanted to say earlier. I told linezolid being misused drug in OPD, even for skin infection. People are writing linezolid. Please do not use it for community acquired infection. This is a reserve drug. And one more thing, this is a reserve ATT drug. If you are using it right and left, TB bacteria, the bacilli will develop resistance against linezolid, and we will have no other drug. And this is a recent one. It is like snake oil. This representative, they come and sell you ferropenum. It belongs to actually penum group of antibiotic. This is not a carbapenem actually, but actually what the representative say, this is equal to meropenem. No, this is not equal to meropenem. This covers CSBL. Yes, it is indicated for only for UTI and approved in Japan and India, but people are using it for even other infections. They think that this is a meropenem, like whenever a child gets severe infection, they go for ferropenem. No, never use. This is a useless drug, I would say, for other infections, except you can use it for UTI. And one more thing, being a close relative of carbapenem, this may induce carbapenem resistance. So please do not use it in our OPD practice. So the key points: choose antibiotic based on the susceptibility and cost, avoid marketing driven prescribing, and preserve the newer antibiotics. Example is the fifth generation cephalosporin, ceftaroline. Do not give it for your IP patients. This is a reserved drug for MDR, gram negative bacteria. Do not use it. The fifth one, another one, like after a child is admitted, what we think that continuing IV antibiotic for 5 to 7 days, that is the best thing. We do not discharge the patient. One thing, we will get more money when they are in our hospital. And second, we think actually what we are doing better for the patient, because IV antibiotics are superior and oral drugs are less efficacy. Is it so? No. The reality is oral antibiotics, they have comparable efficacy. You can see in this slide the bioavailability of these drugs. More than 90%: levofloxacin, clindamycin, metronidazole, doxy, rifampicin, fluconazole, voriconazole. See, all these drugs now you'll be using for very sick patients, and even when the line is not there, you'll be going on pricking the child. Fluconazole, voriconazole, they have 90% bioavailability if you are given orally, and linezolid, of course, and even amoxicillin, all these drugs. So what we have to, ultimate aim is to kill the bacteria. This can be through any route, oral or IV or whatever route. So two things you can do. One, you can choose one of these antibiotic as a step down drug, or you can, when the IV line, you do not want to give a IV line and a moderate a child having moderate infection, you can go for these drugs. So the benefits of IV to oral switch after second or third day would be cost saving and the reduction in the length of hospital stay. This will be useful in our government setup, even in private setup. If you want to do good for the patient, definitely you can do this. And avoidance of central venous catheter placement and the reduction in the IV monitoring. Definitely put a IV line and pay when you are admitting. There will be, it's a labor intensive process. And there is one more misconception in step down. We have to give the same antibiotic you are giving IV, that has to be given for oral. No, this is not the case at all. Because if you are using IV ampicillin, you cannot give oral ampicillin, which is like oral ampicillin is available, but this will not, it's not appropriate. You can go for oral amoxicillin. So there are three types of actually IV to oral switch. Sequential therapy, where you can go for the same drug like levofloxacin, you can go for oral IV levofloxacin to oral levofloxacin. And switch therapy, where you can go to same drug of the, another drug of same group. Like you are giving IV levofloxacin, you can go for oral ciprofloxacin. And the most commonly used and better would be step down therapy, where you are going for a different group of drug, but only thing is that has to cover the same group of bacteria. So you are giving ampicillin, which is not available orally. After 2 or 3 days, when the child improve, you can go for a coamoxiclav. Only thing, you have to give the better dose. The dose would be 60 to 80 milligram per kg, something like that. And this is the one we, when I was outside, when I was practicing, we in the hospital where I worked, they were using this in Middle East, this antimicrobial switch therapy. When a child was getting ceftazidime or cefepime, the suggested oral conversion after third day or fourth day would be with the ciprofloxacin or ofloxacin. When the child was getting ceftriaxone or cefotaxime, we can go for cefixime. Clindamycin, of course, oral clindamycin. And imipenem or meropenem, go for cipro with metro or ofloxacin with metro. And metro, of course, you can go for oral metro. So we'll move on to the myth number 6. We always think that combining multiple antibiotics improves outcomes because at least one antibiotic will do the work. This is another myth. The examples, the famous example already told, the ofloxacin arnidazole or ofloxacin metronidazole, it is utterly useless. I already told the incidence of parasitic infections in a diarrhea would be 3 to 5%. So you will be 95% wrong when you are using this combination. Only when it is indicated. Now you can see in microbiology book, they will tell the bacillary dysentery and amoebic dysentery, how it will write. And GRD is also the stool, it will be like a fat, bulky, malabsorption. The stool would be like a malabsorption. So when those things are there, we can use metronidazole or arnidazole. Otherwise, do not use. And because these increase the toxicity and the resistance, and some of them have a lot of adverse effects. And one more thing, now latest, the representatives, they push these drugs, cefixime with clavulanic acid, cefotaxime with clavulanic acid. Okay, what about this? Do they work? No. It has been found, a lot of studies have shown this combination is an irrational one. It is not going to work. This clavulanic acid, it will only cause diarrhea in that patient. It is not going to help the cefotaxime. And another one is cefixime with the dicloxolane, lactobacillus, another useless combination. So all these combinations has to be avoided. The key point, culture guided monotherapy and the synergistic combinations are used to be only in specific cases. We all know in infective endocarditis or suspected pseudomonas, we go for two drugs. We know TB regimens and ART, and avoid redundant combinations. We are sometimes seeing patients receiving meropenem with ceftriaxone or piperacillin tazobactam with cefotaxime. No, two beta-lactams are not at all needed. No, it's a redundant one. Myth number 7. If fever persists, change antibiotics. This is a common myth we have. Usually we change antibiotics after 2 or 3 days, but some of the people, they change within 1 week. I've seen people changing from they change from ceftriaxone to piperacillin tazobactam and meropenem. They went to even cholesterol by the end of 1 week. They just go on changing the drugs if fever persists. What is the reality? We all know that fever is a natural phenomenon to any infection. It can happen during the course of an infection, and it is a host immune response actually. And non-infectious causes also can cause fever. And there sometimes there might be abscess which is there, hidden abscess which is causing this fever. So prematurely switching antibiotic is going to lead to a lot of toxicity, and definitely it is one of the cause for antimicrobial resistance. So what you have to do, a thorough clinical assessment and lab data. The biomarkers will help you here, or imaging is going to help you before you are going to change the therapy. So what the idea say, guidelines say that for community acquired pneumonia, the fever may persist for 48 to 72 hours. You have to wait for minimum 3 days before you are going to change the antibiotic. Never change antibiotic on the second day or third day. You wait for 3 days, and fourth day, depending on the patient condition and also the clinical trend, the respiratory status, WBC count, CRP, all those things will tell you whether to go for another antibiotic or continue with the same antibiotic. Similarly, the study in clinical infectious disease on bloodstream infections found that fever resolution in bacteremia, the example would be typhoid, enteric fever. The fever resolution will take minimum 5 to 7 days. So when you suspect enteric fever, you started ceftriaxone, wait for minimum 5 days. Don't go, change the antibiotic on third day, fourth day, thinking that ceftriaxone resistance is there. No, ceftriaxone resistance has not been reported from our country. It has been reported from Pakistan and from Iran and from some other country, but India, I think maybe 1 or 2 places it has been reported, but it's not widespread. You continue ceftriaxone for 5 to 7 days. Then, if patient not responding, you can go for another drug, right, with higher antibiotic. So the key points, you have to assess the clinical context, evaluate the overall clinical response rather than focusing only on fever, and consider timing, give sufficient time, minimum 72 hours, and investigate alternatives. Of course, I told already, non-infectious causes also would be there. Sometimes drug fever, the famous example. In one of my patient in my unit, we given so many drugs, and at the end we got now fed up and we stopped all drugs, and patient become okay because it's drug fever. And IV line thrombosis, IV line infection, sometimes that could be the cause. So IV line has to be changed after 48 to 72 hours. That also one of the cause for fever. And complications like undrained abscess. Always look for abscess if the fever persists with high swinging fever with the chills. Don't change antibiotic. Look for any underlying any abscess. Right. So myth number 8 is a very common one. That is the second clinical scenario I told, treating the culture report. Every positive culture means antibiotic treatment, and switch antibiotic even if the patient is improving. Is it so? What is the reality? That a lot of studies have shown that positive cultures could be colonization, especially in the clinical scenario I told. It was cons, it was probably, the staff nurse who took the blood sample, probably he has contaminated that sample, and that is why cons is coming when the child was having a community acquired pneumonia. Where will you expect cons? Cons, when a child was sick, if child was intubated and put on ventilator for minimum 5 days to 7 days, where you expect cons? Cons you do not expect in a child who has come from the community. So positive cultures has to be, sometimes they can be of colonization. So treating colonization unnecessarily will contribute to antibiotic resistance and a lot of other things like increased healthcare costs. So we have to clinically correlate, look at the symptoms and signs of infection, look at the WBC count and source of culture, then determine whether treatment is warranted or not. Especially if the urine and sputum, sometimes they are all the chance of contamination or super infection might be there. So better avoid changing antibiotics in these conditions. And what IDSA says, for asymptomatic bacteria, there is no need to start antibiotic except in specific scenarios like pregnancy or any urological procedures. Similarly, for VAP, the American Thoracic Society IDSA guidelines say that the clinical criteria has to be used. You don't go by only the positive endotracheal culture. If the clinical criteria also matches that of VAP, then only you start antibiotic. Otherwise, you treat it as you just think of as colonization and do not change the antibiotic. So switch antibiotic if culture shows resistance, even if the patient improves. Is it correct? No. If the patient is clinically improving, the resolution of fever is there, and symptoms like the second scenario I told, improved symptoms, laboratory markers, the CRP is coming down, CBC is also the WBC count, which was previously high, coming down. No need to switch antibiotics. You just continue that, and even if the culture report shows some bacteria, nothing to worry. You continue antibiotics because what happens is in vitro resistance, they do not correlate with in vivo the effect of the bacteria by the antibiotic. So with clinical failure. So there are so many other factors like tissue penetration, immune response, and biofilm formation. Also, they influence outcomes. So do not switch antibiotics looking at only at the culture. And I already told this, the IDSA guidelines for MRSA suggest that you continue vancomycin even if the culture shows intermediate resistance. Because what they say, the intermediate resistance, you can continue antibiotics, and only thing is you have to look at the therapeutic, the drug monitoring. That is the only thing you would know, whether the drug level is more than that curve. And Journal of Antimicrobial Chemotherapy that says that in carbapenem resistant enterobacterial infections, you continue this carbapenem. Only thing you have to give the continuous infusion of this carbapenem over a period of 6 hours. That is the most, it still achieved clinical cure. The key point I wanted to say for this myth, positive cultures, you have to distinguish colonization from infection. And antibiotic switching, do not switch antibiotic based only on culture reports. You have to have a holistic view of that patient. And myth number 9, longer antibiotic course are always better. We always think that giving antibiotics for 7 to 10 days is better. You keep the patient in our hospital, or you want to continue antibiotics. No, the extended course are going to only cause a lot of problem. A recent trial in NEGM showed that for community-acquired pneumonia, a 5-day course of antibiotics is as effective as a 10-day course with fewer adverse effects. And IDC 2021 guidelines says that for uncomplicated urinary tract infection in pediatrics, 3 to 5 day course of antibiotics is more than enough. Even 3 days is enough. So the next slide, I'm going to put various RCT which are supporting the shorter course of therapy for community-acquired pneumonia, atypical, VAP, complicated UTI, intra-abdominal, all these things. You can see all these are non-inferiority trials. They show they are equal. Even septic arthritis, neutropenic fever, where short course, you can see here short course, and this one is a long course. And so many RCTs, they are showing everything is equal. So do not, don't chase the longer course of therapy. You have to use a shorter culture-guided antibiotic courses, which are they are equally effective and reduce the risk, and follow the evidence-based durations, 5 days for pneumonia and 3 days for uncomplicated UTI. We come to the final myth, double anaerobic coverage. This is another myth, another thing, a lot of sometimes when we are seeing when we see in the case, especially in patients who are admitted for some problem, especially the surgeons, they make this multiple antibiotics for anaerobic coverage. In intra-abdominal infection, you can see this double anaerobic coverage, like they put meropenem as well as metronidazole, or sometimes peptides with the metronidazole. Single agent is sufficient. So now we have to tell them antibiotics that cover anaerobes. Now this is a famous mnemonic: Campscum, clindamycin, augmentin, metronidazole, peptides, carbapenems. Unacin is I think this one, and moxifloxacin. Overlap actually, when you are putting two, it's going to cause problem. And peptides and meropenem, they have anaerobic coverage. When you are using peptides or meropenem for an intra-abdominal infections or some other, you want to give anaerobic coverage, no need to add flagyl. and avoid combining similarly metronidazole with clindamycin, because clindamycin also covers against this anaerobes. And this was a picture I'll put similar to that above diaphragm amoxicillin, below diaphragm cefixime. Above diaphragm and if you suspect anaerobic infections, clindamycin is the best one, and below the diaphragm metronidazole. And everywhere, if you are in doubt, everywhere you can use beta-lactamase combinations, unacin or josin, and carbapenems, of course, and moxifloxacin. They will cover everywhere. Right. We come to the end of my lecture. Carry home points. Use narrow-spectrum antibiotics whenever possible. Do not use antibiotics, during in or OPD practice. Use when only appropriately indicated. If you want to use narrow-spectrum antibiotics. That is the full thing I wanted to say. And base therapy on clinical guidelines, not on myths. Avoid antibiotics for viral infection. Already I told, shorten the treatment durations. Promote stewardship to combat AMR. Not only it's like the job doesn't finish here. You have to tell your colleagues who haven't attended this lecture. Tell your colleagues not to misuse antibiotics, and rational prescribing is going to save lot of lives, and even it is going to save us. In another 20-30 years we will be old people, and if you get a infection, if no antibiotics there, who will save us? So think of ourselves, you think of yourself, and do not misuse antibiotics. Thank you very much. Thank you for this opportunity.
Thank you, Dr. Rajkumar. I think we had some absolutely wonderful CME. I think we started with the objective of trying to educate our people about the rational antibiotic therapy, and I think we achieved our aim. So very much thanks to Dr. Rajkumar and Dr. Manasekar. So I don't see a lot of questions, except that I don't know about others. I learned a few things. I learned Ninja from Dr. Manasi, and of course, I knew about it, but I just had to really go recover. Remind of the antibiotic classification by WHO again. So thank you very much, Dr. Rajkumar. Dr. Vinod or anybody else, if they want to have any other question, we can open up for us. The forum is open for discussion. Any other questions, any doubts? Usually, I don't have the opportunity of listening to Dr. Rajkumar because both of us, we keep running around. So when he talks, I hardly listen to him. So, but this was a very impressive one. Of course, Manasi, I have heard before in the past as well. So thank you very much, both of you. Any other questions? Okay, looks like everybody is clear, but based on what, there are only a couple of questions which was about, is it available in the YouTube, because people do want to go back and listen to it. It is available in the YouTube. I request people to pass it on to the other colleagues so that they can also benefit from this. So thank you very much. Over to Dr. Vinod for further concluding remarks. Dr. Vinod, Dr. Sharma. Welcome, sir. Any comments, sir, from you, sir? Welcome, sir. Dr. Johnson boss, please.
Yes, sir. Good evening. Thank you, sir. Thank you for excellent talk. Thank you, madam, for excellent talk. And it was very informative and for our members. Over to Thiru, sir.
Thank you, sir. Thank you very much, sir. Okay, so I think without any further, we would like to end the session. Thank you once again, Dr. Rajkumar, for inviting us. A very useful topic. And we hope to listen to more of your topics again and sing the same with Dr. Manasi. Thank you.
Thank you very much.
Thank you.